The first topic I'm going to discuss is called hairy cell leukemia and its variant. Facts first, is an uncommon lymphoma, less than 2% of the cases. There's a strong male preponderance, 4 times more common in male for some reason. And it is the origin of this lymphoma cells is basically the memory B cells, and it's a mature, slow-growing lymphoma. Now, the key points that you have to remember in this hairy cell leukemia, you can imagine a cell. It has got a lymphocyte, which has got a kidney-shaped nucleus, and there are fine cytoplasmic projections all around. Commonly described as fried egg appearance, okay? And the classical features that you see in the morphology on a blood film is basically, you can see a kidney-shaped nucleus, there are fine projections, and there is classical monocytopenia, okay? So these are the key morphological features of the hairy cell that you should know about. And in terms of the projection, you can understand later on that it depends whether the projections are on the side, whether they are villous, whether they're polar, to differentiate between different subset or of lymphomas like splenic marginal zone lymphoma or splenic red pulp lymphoma. Now, the pathogenesis is basically there's a BRAF V600E mutation, which is seen in almost 100% of the classical lymphomas. And basically what it does is cause activation of the MEK pathway, the MEK pathway, which is inherent GTPase, which get activated, and it causes downregulation of CXCR5, which is a cytokine receptor. And it also causes the activation of the inflammatory complex with IL-6 and and tumor necrosis factor. Now, the key thing is these lymphoma cells, they hone onto the bone marrow, they go onto the spleen, they go onto the liver, and very, very rarely they go onto the lymph nodes, cause lymphadenopathy. So the classical situation when they go onto the bone marrow is they cause fibrosis. The way I remember is basically I feel that these lymphocytes are causing a lot of inflammation, and the pointy file projection, I imagine them to cause fibrosis all around wherever they go. And the other thing which I can see that there's often when you do bone marrow on these patients, there is a dry tap. And because of this fibrosis and everything, there's often an associated cytopenia. So whenever you see a blood film with a lot of cytopenia, always be on a lookout for these abnormal cells with hairy cytoplasm. When they involve the spleen or the liver, often they involve the sinusoid. The red sinusoid is in particular in spleen, and they cause splenomegaly, which often presents as abdominal discomfort, early satiety, and abdominal fullness. When they involve the liver, they cause sinusoidal obstruction, they can cause enlargement, and occasionally, as I said, very rarely they can present with a large lymph nodal mass, okay? Now, the clinical features is, as I said, is because of the pancytopenia. You can have infection, you can have anemia, you can have thrombocytopenia, and classically there is monocytopenia. You can find on the blood film, you can find these hairy cells. On the bone marrow, you've got the classical feature, which we'll describe just in a wee while. You've got organomegaly, and obviously you can have the constitutional symptoms of a lymphoma. The bone marrow, the key points to remember is a dry tap. There's you can see the appearance looks like a honeycomb. There are blood sinusoids, and there is sometimes a pseudosinus formation, and there is fibrosis. Okay. Now this is the most important bit. We have to remember the CD markers of these hairy cells. So they've got the classical markers of the B lymphocyte, which is CD20, 11C, FMC7. They also have got, I usually feel them as a number of 3, so 103 and 123. Annexin A1 and cyclin D1, which is out of this, annexin A1 is the most specific to hairy cells. And then we also have CD200, which is a marker of a mature B cell. There's also a high expression of surface immunoglobulin and 25 positivity. So to reiterate, the CD20, 22, CD11C, 103, 123, then there is an XNA1, FMC7, CD200, cyclin D1, and immunoglobulin, surface immunoglobulins. Okay. Now, going back to the differentials, so if you see cells like these with fine hairy projection on a blood film, the most common differential that we have should always have 4 in the mind. The first one is hairy cell variant. first one, of course, is hairy cell leukemia. The next one is going to be hairy cell variant, which is different because it can have variable projection. The classic thing it has got 5 nucleolus inside the cell. Okay. The next one is splenic red pulp lymphoma, which has got polar which has got polar villus projections, and the last one is splenic marginal zone lymphoma, which has got villus as well as polar projections. Okay, so that's a difference between all 4 of these. In terms of immunophenotyping, as you know, we have already talked about the hairy cell leukemia. The classic thing to remember is that it is CD27 negative. In terms of the variant, the only thing which it is positive for is CD20. It is positive for 103, 11C, and it is positive for CD27, which can be a good differentiating factor. Okay. On the other hand, the splenic red pulp lymphoma is positive for CD20, CD27, and it can be positive or negative for 103 and 11C. And splenic marginal zone lymphoma is CD20, CD27, and DBA44 positive. Now, classic thing is all 4 of them are DBA44 positive. So it is a marker of seeing if there is any kind of clinical response or partial response. Okay. The molecular markers that we know is for hairy cell leukemia is BRAF 600V, V600E, and is in the variant it is MAP2K1 mutation. Okay, so just remember this is slightly different from the MAP activation, MAPK activation in the hairy cell. In terms of the splenic red pulp lymphoma, it is CCND3, and in terms of marginal zone lymphoma, splenic marginal zone lymphoma, it is a Notch2 and deletion 7q along with KLF2 mutation. Okay. Now, how do we treat hairy cell leukemia? So if the patient is asymptomatic, you just found out on the blood film, the most common treatment is just watch and wait. And if the patient starts to have symptom, and when you think about treatment, you have to understand that purine analogs are the gold standard. They've got a very high overall responses, around almost 90 to 100%, and the clinical remission is seen in around 70 to 90% of the patient. So there are 2 main purine analogs that we can use in hairy cell leukemia. The first one is called cladribine, and the second one is called pentostatin. There's a slight difference in the way both of these are administered. Cladribine is usually given as an IV infusion or a subcut infusion given either 5 or 7 days. So there is a bit of a flexibility in terms of how this is given. On the other hand, pentostatin, the way I remember, is kind of stopping things. So it's given as a recurrent infusion every 2 to 3 weekly. And overall, once you're given cladribine, we reassess by doing a bone marrow in 6 months' time. On the other hand, if you're given pentostatin, we just reassess things once you're given 8 or 9 injection, and then depending on the bone marrow, if there is clinical remission, we just give few more.